day, I'm Dr. Achibong, Senior Registrar of Obstetrics and Gynecology at the Obafemi Awolowo University Teaching Hospital, Ile-Ife, Southwest Nigeria. I'll be giving a lecture on placental anomalies and retained placenta. At the end of this lecture, you'll be able to know the various placental anomalies and their clinical significance. You should be able to know the risk factors and the management for retained placenta. We'll be following this outline: basic anatomy and physiology of the placenta, some common placenta anomalies, retained placenta, and then conclusion. The placenta means a flat cake, and this term was given by a man called Riagius Columbus in 1559 when he was trying to describe the structure, the anatomical structure of the placenta. At term, the average measures of a delivered placenta are as follows. It has a diameter of 22 centimeter, it has a central thickness of 2.5 centimeter, and it has a weight of about 450 to 500 grams. The placenta has two surfaces. There's a maternal surface and there's a fetal surface. The maternal surface is the basal plate, and it is divided into clefts called cotyledons. These clefts mark the site of internal septa which extend into the intervillous space. The fetal surface is called the chorionic plate, into which the umbilical cord inserts typically in the center. I want you to take note of that the umbilical cord should insert typically in the center. Any deviation from this will lead to some anomalies which we are going to discuss later. The chorionic plate and its vessels are usually covered with thin amnion, which can be easily peeled away from a post-delivery specimen. The placenta is developed from two sources. The principal component is fetal, which developed from the chorion frondosum, and the maternal component, which consists of the decidual basalis. This diagram just illustrates what I've said earlier about the chorionic plates, the one upper, and the basal plates, which belong to the maternal part. And there are some structures there, which are these structures here. These are the intervillous spaces and the villi. And this structure here is the umbilical cord, which is inserted typically at the center. Here is a more detailed diagram of what has been described earlier. So we have the chorionic plates, we have the basal plates, we have the chorionic villus, and we have the umbilical cord with all the arteries there. What are the placenta functions? Placenta performs various functions: circulatory function, uteroplacental circulation, fetal placenta circulation, and also gets involved in spiral artery changes. Now, this is important because there are some conditions in obstetrics that are associated with defective or abnormal circulatory function. For example, one of the functions of the placenta is circulatory function and is involved in spiral artery changes. If the spiral artery changes are not adequate, it can lead to a condition called preeclampsia. And also, uteroplacental dysfunction could lead to intrauterine growth restriction and even intrauterine fetal death. The placenta also has some endocrine function. In other words, the placenta produces a lot of hormones. Some of the hormones produced by the placenta include progesterone, pregnancy-associated plasma protein A, B, C, adrenocorticotropic hormone, relaxin, all the forms of estrogen, estrone, estradiol, estriol, human chorionic gonadotropin, human chorionic somatotropin, human chorionic corticotropin. So these are all the various hormones that are produced by the placenta. Some other hormones are produced by the placenta that are not listed here, but it's worthy of note that the placenta produces a lot of hormones for its endocrine function. The placenta also performs some transport function and transport gases, nutrients from the mother and to the fetus. One of the various forms of placenta anomaly that we're going to consider today is placenta succentoriata, or a succenturate lobe of the placenta. This usually occurs when there is one or small lobes of the placenta the size of a cotyledon, which may be placed at varying distances from the main placental margin. It could be connected to the main placenta through some vessels. However, in some cases, there may be absence of communicating blood vessels, And when this occurs, it is called placental sporia. The incidence of placenta succinturata is about 3%. Now, how do we make a diagnosis of placenta succinturata? The diagnosis is made following inspection of the placenta after its expulsion. And this is one of the reasons why it is important that after a woman has delivered, one should inspect the placenta, usually under running water, to check and to be sure that the placenta has been delivered completely and that there are no accessory lobe or placenta succinturata that is left behind in the uterus. Now, how do we make a diagnosis? After inspecting the placenta, one can see a gap in the chorion, and one can also see torn blood vessels on the margin of the gap. And this diagram shows placenta succinturata. So this is the main placenta, and then this small lobe here is the accessory lobe with communicating vessels. So this is an example diagram showing placenta succinturata. This diagram also shows placenta succinturata. Those two arrows seen there, those are the accessory lobes. This is the accessory lobe, and this is another accessory lobe. What's the clinical significance of placenta succinturata? The clinical significance is the fact that it can lead to postpartum hemorrhage, which may be primary or secondary. So if a woman has delivered and peradventure the woman had a placenta succinturata and the accessory lobe was left behind, it can lead to postpartum hemorrhage, either primary or secondary. It can also lead to subinvolution of the uterus. In other words, after delivery, the uterus will not return back to its pre-pregnancy state on time. And also it can lead to puerperal sepsis, because if the placenta is left behind, it could be a focus for infection, causing puerperal sepsis. What's the treatment for placenta succinturata? Whenever a diagnosis of a missing lobe is made, the uterus should be explored and the accessory lobe should be removed as soon as possible. Placenta fenestrata. In placenta fenestrata, the central portion of a placenta disc is missing. And some instances, there may be an actual hole in the placenta, but most often the defect is only in the villous tissue and the chorionic plate is intact. It may erroneously prompt the search for a retained or missing cotyledon, and it usually does not have any clinical significance per se. Now, for battle door placenta, I said earlier that the cord should be attached at the center of the placenta. However, in battle door placenta, the cord is attached to the margin of the placenta. Now, if this placenta is associated with lower implantation, there is a chance of cord compression in vaginal delivery, which may lead to fetal anoxia, or in worst case scenarios, can lead to death. Otherwise, it has got little clinical significance. Now, this diagram shows a battle door placenta. So we can see the cord being inserted at the margin of the placenta. Velamentous insertion of the cord, also called velamentous placenta. In velamentous placenta, velamentous insertion of the cord is attached to the membranes. Now, if there's a leash of blood vessels happen to transverse through the membranes, overlying the internal os, and in front of the presenting part, it is called vasa previa. Rupture of the membranes involving the overlying vessels will lead to vaginal bleeding, and the blood is usually entirely fetal blood, and this may lead or result in fetal exsanguination and death. So in velamentous insertion, the cord inserts on the membrane, and some vessels run over the membrane. So if a woman has a rupture of membrane, either spontaneous, artificial rupture of the membrane, the vessels will bleed, and because these vessels come from the fetus, it can lead to fetal exsanguination and death. That's the clinical significance of velamentous insertion of the cord. Now, what's the management for it? In the presence of fetal bleeding, urgent delivery is essential, either vaginally or by cesarean section as the case may be, and the infant's hemoglobin should be estimated, and if necessary, blood transfusion should be carried out. And this diagram also shows the various types of placental anomaly that have been described earlier. This here is what I've just finished describing. Velamentous insertion of the cord. This is the cord inserting on the membrane. This is the membrane, and these are the vessels running on the membrane. So if there's a rupture of the membrane, these vessels will also rupture with the membrane, and because the bleeding is essentially fetal, it can lead to fetal exsanguination and death. This diagram also shows battle duct placenta, the cord inserting to the margin of the placenta. Now this is a placenta subcentriata. This is the main lobe of the placenta, and this is the subcentriate lobe or the accessory lobe, and these are the vessels that are communicating. Now I'll still describe this later in the presentation. The placenta membranacea. The incidence of placenta membranacea is about 1 in 20,000 to 40,000. What happens in membranacea is the fact that during placenta development, the primitive chorion layer differentiates into the chorion levi and chorion frondosum at about 8 to 10 weeks. However, in placenta membranacea, this differentiation does not occur, and the fetal membranes are completely or partially covered by chorionic villi. So in placenta membranacea, the placenta is unusually large, and the fetal membranes are completely or partially covered by chorionic villi. There have been some suggested etiologies of placenta membranacea. It can be caused by endometritis, poorly developed blood supply, Desidera basalis, or excessive blood supply, failure of the genesis of the trophoblasts, resulting in development of a primitive form of placenta, deep implantation of the ovum, and atrophy or hypoplasia of the endometrium. That's one of the suggested etiologies that could cause placenta membranacea. Diagnosis by ultrasound is difficult, and the clinical manifestation of placenta membranacea is diverse. However, proper and early diagnosis of placenta membranacea can provide obstetricians with accurate information and help them make proper arrangement of delivery, which may improve the neonatal outcome. What's the clinical significance of placenta membranacea? Because in placenta membranacea, the placenta is unusually large, it could lead to encroachment of some part of the lower segment, leading to placenta previa. There could also be imperfect separation in the third stage of labor, leading to postpartum hemorrhage, and there could also be a chance of retained placenta is more, and manual removal becomes more difficult. Some studies have also found an association between fetal growth restriction and placenta membranacea. Another placental anomaly that we consider is extrachoreal placenta. As I said earlier when describing the anatomy of the placenta, that there's a chorionic plate and there's also a basal plate. The chorionic plate is the fetal side, and the basal plate is the maternal part of the placenta. Normally, the chorionic plate extends to the periphery of the placenta and has a diameter similar to that of the basal plate. With extrachoreal placentation, the chorionic plate fails to extend to this periphery and leads to a chorionic plate that is smaller than the basal plate. There are two types of extrachoreal placenta. There's a circumvallate placenta and there's placenta marginata. In circummarginate placenta or placenta marginata, fibrin and old hemorrhage lie between the placenta and the overlying amniochorion. Whereas in circumvallate placenta, the chorion and amnion is thrown into a double fold. Where in circummarginate placenta, fibrin and old hemorrhage lie between the placenta and the overlying amniochorion. Now this diagram just illustrates extrachoreal placentation. Now this is circummarginate placenta, in which this is the chorionic plate and this is the basal plate. There's a space here, and in circummarginate it is filled with fibrin, while in circumvallate the amnion and the chorion, they are thrown into double folds. So we can see that the chorionic plate is smaller than the basal plate, leading to some spaces here which will be filled by deposits. Clinically, most pregnancies with an extrachoreal placenta have normal outcome. However, some observational studies, which the diagnosis was made by personal examination, circumvallate placenta was associated with increased risk of antepartum bleeding, preterm birth, excessive vaginal discharge, also called hydroria gravidarum, and also retained placenta or fetal membranes. Placentomegaly. Placentomegaly is defined by a placenta thickness of greater than 40 mm, and primarily it results from villous enlargement. And whenever placentomegaly is encountered on ultrasound scan, it's important for one to look for other conditions that could cause placentomegaly. And placentomegaly can be secondary to some conditions. Conditions that could cause placentomegaly include diabetes, hydrous fetalis, partial mole, infections like syphilis, toxoplasmosis, and cytomegalovirus. Placenta tumors. Um, Placenta tumors, one of the commonest placenta tumor is chorioangioma. It's a benign tumor with an incidence of about 1% and usually may be associated with elevated levels of maternal serum alpha fetoprotein. Classically, chorioangioma appears as a round, well-circumscribed hypoechoic lesion that protrudes from the chorionic surface, that is the fetal surface, and on ultrasound scan is associated with increased flow on Doppler. Now, this fine ultrasound scan is important because it helps us to differentiate it from an amniotic band. Now, this shows the diagram of a chorioangioma. So this is the chorioangioma, well-circumscribed hypoechoic lesion found on the chorionic plate, that is the fetal surface, and this is the cord, and this is the chorioangioma. Small chorioangiomas, those less than 5 cm, are usually asymptomatic. Large tumors may be associated with hydrus fetalis, fetal anemia, and fetal growth restriction. And sometimes these large tumors have been managed by occlusion of the vessels in order to shrink the chorioangioma. Placental tumors can also be secondary or metastatic. Some tumors that can metastasize to the placenta include melanoma, lymphomas, even some breast tumors can also metastasize to the placenta. For retained placenta, the third stage of labor is critical in managing a woman in labor. This is because there are a lot of complications that could arise from the third stage of labor. Currently, the active management of third stage of labor is advocated, and the active management of third stage of labor includes the use of oxytocin, particularly oxytocin, controlled cord traction, and uterine massage was initially employed, but currently it is not recommended for the management of third stage of labor. What's the mechanism of placenta separation? Now, after delivery, there's usually shortening, what is called retraction of the uterine muscles, with subsequent reduction of the placenta site surface area. After delivery of the fetus, there is contraction and retraction of uterine muscles, and then the placenta site surface area also reduces, is said to reduce by about 50%. And because the uterus is contractile, but the placenta is not a contractile structure, it is ultimately sheared off. And there are two methods of shearing or separation of the placenta. The first is central separation, and the second is marginal separation. In central separation, the separation or shearing of the placenta occurs in the middle of the placenta, and it's also called the Scooch method of separation. There's also the marginal, in which the separation or the shearing starts from the margin of the placenta, also called the Matthews-Duncan's method of shearing. For the predisposing factors of retained placenta, basically retained placenta can be caused by poor management of the third stage, can be caused by prematurity. This is because for preterm fetuses, if there is a premature delivery or preterm delivery, the plane of cleavage between the placenta and the uterus is not well formed, and so it may be difficult to deliver the placenta. Poor myometrial contractility can also be a predisposing factor for retained placenta. So if there's fibroid, if there's a need for induction or augmentation of labor, it means that uterus may not contract properly, and there could be a risk factor for retained placenta. If there's anything that could cause a disruption in the myometrial placental interface, like previous abortion, preeclampsia, uterine anomaly, a previous uterine scar, these are things that could predispose a woman to having a retained placenta. The placenta can also be morbidly adherent. Also, the use of ergometrine as management of the third stage of labor can also cause retained placenta. But in this case, it will lead to a trapped placenta because ergometrine causes contraction of both the upper and the lower uterine segment. Therefore, even if the placenta are separated, the placenta will be trapped because it will not be able to deliver from the lower uterine segments. What do we do if you have a case of retained placenta? What's the management of retained placenta? Once a patient comes with retained placenta, one should take, particularly if the patient was not managed in your facility or your center, one should take a brief history, establish intravenous access, and take relevant samples. Check the vital signs, because sometimes this woman may be in shock, hypovolemic shock. So you want to check the vital signs. We want to drain the bladder of this patient, because a full bladder may not allow the uterus to contract properly and lead to the placenta being retained. One should administer oxytocin to the patient, and one should also attempt controlled contraction where the placenta may deliver. Now, if all this fails, after draining the bladder, giving oxytocin, and attempting controlled contraction, if this fails, then a decision has to be reached to perform manual removal of the placenta for the patient. So manual removal of placenta is done in the theater. The reason why it's done in the theater is the fact that it could be associated with some complication. The placenta may be morbidly adherent. Therefore, if there's false removal, it might lead to the patient bleeding torrentially, and then a need for other surgical intervention, which may even necessitate hysterectomy. Moreover, for manual removal of placenta, the patient needs to be adequately relaxed, and anesthesia needs to be administered to this patient. That's why it should be done in the theater. General anesthesia is usually administered to this patient, particularly for uterine relaxation. The patient is placed in dorsal autonomy position. Asepsis is maintained. Whoever is performing the manual removal, the arch should place one hand on the abdomen to steady the fundus and push the uterus downward. The other hand, which should be lubricated, should follow the cord into the vagina and through the cervix to the lower margin of the placenta. Once the lower margin of the placenta is reached, the placenta is detached by sweeping the hand from side to side within the cleavage plane between the placenta and the uterine wall. Once separation of the placenta is done, the uterine wall is checked to be intact. Oxytocin are administered. Broad spectrum antibiotics is also administered. It's important to note that after the placenta has been removed, it should be inspected to ensure that it is removed completely. Now, this diagram just illustrates the posterior of manual placenta. The arch uses the finger to traces the cord, use the cord as a guide through the vagina to the cervix up to the lower margin of the placenta. And when the lower margin of the placenta is reached, it is swept. The hand is swept from the hand. One insinuates the hand between the placenta margin and the uterine wall, the cleavage plane between the uterine wall and the placenta margin, and then it is swept from side to side until the placenta is delivered from the uterine wall. One should note the hand of the arch here. This hand is placed on the fundus. This is to steady the fundus and to push it downwards. Other methods of management of retained placenta involve the use of intra-umbilical injection of oxytocin. About 20 to 50 national units of oxytocin can be diluted with 30 ml of sterile water or normal saline and injected via the umbilical vein. The principle how this works is the fact that it will deliver high concentration of oxytocin to the vitreal placenta myometrium and cause the placenta to deliver. Although this is not currently recommended, but this method has been tried for management of retained placenta. In conclusion, placental anomalies, though rare, can provide vital clinical information that can help us to manage our patient properly. Therefore, knowledge of the various anomalies and their clinical significance is important, and proper management of third stage of labor is crucial in preventing retained placenta. Thank you for listening.